Hello, I'm Rick Matsen. I'm chairman of the Department of Orthopaedics and Sports Medicine at the University of Washington. It's my pleasure today to get to talk to you a little bit about one of the exciting advances in orthopedics and sports medicine, and that is the replacement of a damaged shoulder joint. When a shoulder joint is affected by arthritis, the normal cartilage that covers the joint surfaces is removed. Then the bones have to rub on each other without that interposed cushioning layer. This results in pain, stiffness, and limited function for the patient, so that they're unable to carry out their activities of daily living, such as sleeping, taking care of their personal hygiene, driving, and going to get groceries. Fortunately now, there is a method by which this rough joint surface can be replaced by an artificial joint surface, shown here. This implant fits down inside the bone and takes the place of the damaged joint surface on the ball side. And then on the socket side, we have similarly a replacement, this time made instead of metal out of high-density polyethylene. So when it's inserted on the shoulder blade, it then allows for the smooth articulation of the ball against the socket. One of the important parts of our program at the University of Washington is to make the patient the center of activity. Thus, we take a lot of care to make sure that the patient understands what will be done at surgery, what the alternatives are to the surgery, and their critical role in the postoperative recovery from this operation. We even show many of the patients the video of the shoulder operation as we will show it to you now. This will show you how we are able to get into the shoulder safely, even though it's covered with a lot of muscle and tendons and nerves running all across the shoulder joint. We can show you how we can get safely into the shoulder joint and get out again with the need to cut only one small tendon and to repair that at the end of the procedure. This greatly facilitates the recovery of the patient and enables them to quickly get back to their normal activities. So let me show you now this video of shoulder replacement arthroplasty as we do it at the University of Washington. Here are the x-rays of a patient having total loss of the glenohumeral joint space of the right shoulder. On the axillary view, again the loss of articular cartilage and the posterior erosion of the glenoid is easily seen. We've templated this shoulder to receive a global shoulder prosthesis, showing anatomic reconstitution of the joint surface of the humerus. In this live surgical demonstration, we approach the shoulder through a long anterior deltopectoral incision passing across the coracoid process. The clavipectoral fascia is incised up to, but not through the coracoacromial ligament, just lateral to the border of the coracoid muscles. This patient has a small rotator cuff tear in the supraspinatus. We are now detaching the subscapularis from the lesser tuberosity just medial to the tendon of the long head of the biceps. We work to preserve maximal length of the subscapularis tendon to help the patient regain external rotation after surgery. The humeral head is now exposed.
There you can hear that there's...
Percussing the humeral head demonstrates the loss of articular cartilage over its central aspect and the osteophytes peripherally. Passing a dero retractor behind the head of the humerus brings it nicely into the joint. We'll now enter the humeral head just posterior to the biceps tendon and enter the medullary canal using a canal-finding reamer. Medullary reaming begins here with a 10 millimeter reamer and will continue reaming upwards until we achieve some cortical purchase with the reamer distally. Here this purchase is achieved with a 12 millimeter reamer. Marginal osteophytes are resected using a rongeur and a developmental guidance system called the AOA system is applied here to the medullary reamer, indicating the line of resection for a 48 medium prosthesis. Alternatively, the cut can be guided by an extramedullary guidance system as shown here. A retractor is placed in the joint just medial to the rotator cuff insertion to protect it during the humeral excision. Here the humeral head is excised using an osteotome. We prefer the osteotome because it allows us to carefully plan this cut and to observe the passage of the upper border of the osteotome just inside the rotator cuff. The humeral head is retrieved. The cookie cutter is then inserted down the medullary canal to make the holes for the prosthetic flanges. It's appropriate to orient this cookie cutter so that it makes the cut in 30 degrees of retroversion and parallel to the previously made cut. The congruence between the lower angle of the cookie cutter and the resected humeral head is seen here. The broach is inserted, maintaining the same version, and is impacted to assure maximal lateralization of the broach as it goes down. Any bone extending medial from the collar of the broach is resected using a rongeur. The broach is removed and the glenoid is exposed, again using the Darrow retractor. Here we see the upper rolled border of the subscapularis and the capsule joining with the subscapularis near its insertion. There's the biceps tendon. We'll now release the capsule from the subscapularis as a part of our 360-degree subscapularis release. Tag sutures are placed in the subscapularis and additional capsule release is performed inferiorly. We now have a nice springy bounce to the subscapularis muscle. The capsule and labrum are incised from the glenoid anteriorly. We release the anterior capsule down just past 6 o'clock at the inferior aspect of the glenoid in cases of osteoarthritis where there is some degree of posterior erosion and displacement. Here we're marking the center of the glenoid with cautery, and then with a pinecone burr. And using that as the guide for establishing a normalized glenoid center line using the silver drill. That hole then becomes the guide for the glenoid reamer. Power reaming is now carried out until we have a nice congruent fit between the ream surface and the glenoid round back trial. The congruent fit is demonstrated here with nice security of the component and nice match of the anterior and inferior borders of the trial with the bony glenoid. We then insert the prickly back drill guide, which enables us to produce the 4 peripheral drill holes parallel to the original glenoid centerline hole. We drill the superior hole and then place a fixation pin through it to further secure the glenoid drill guide. We now drill the inferior hole and then again secure it with a fixation pin. This allows excellent security for drilling the 2 remaining holes anteriorly and posteriorly. The pins are then removed with the pliers, as is the drill guide itself. The holes are irrigated using a spray irrigator. A sucker is used to make sure that there is no large hole in the depths of the glenoid holes. Such a large hole might allow for extension of the cement in unwanted territory. Here we're inserting a pegged glenoid trowel and impacting it into position to make sure that we have, again, a good fit of the component to the bone. Here we can see that there is no rock or toggle of the glenoid trowel component. The glenoid bone is again irrigated. And in final preparation for the insertion of the cement, we dry the holes using a sterile CO2 spray from the carbojet. Just before each hole is cemented, we dry it with the carbojet and then insert pressurized cement using a Toomey syringe. In this technique, cement is not applied to the face of the glenoid bone. Our desire is to have direct contact between the back of the prosthesis and the bone of the glenoid. Here the definitive component is inserted into the cement holes and impacted in that position using a glenoid impactor. Any excessive cement is removed from the periphery and from the shoulder, and the glenoid is held into position while the cement hardens. Autograft is obtained from the humeral head. Here we see the security of the glenoid fixation and its match with the anatomy of the glenoid bone. The trowel body is again inserted into the humeral shaft and seated. Various trowel heads are placed to see which gives the desired kinematics. We desire to have approximately 50% posterior translatability of the head with respect to the glenoid and a total of 70 degrees of internal rotation of the abducted arm. The body is removed, and here we're demonstrating the similarity between the trowel body and the bone resected. Here we are impacting bone graft into the proximal humerus. So here's a 12 millimeter impactor impacting the cancellous bone harvested from the head. We find that the use of this soft cancellous bone provides excellent fixation and has eliminated the need for cementing the humeral component in these reconstruction cases. Impaction grafting is continued until a good firm fit of the impactor is achieved. Drill holes are placed in the anterior neck of the humerus for later reattachment of the subscapularis. Prior to insertion of the definitive prosthesis, additional bone graft is added. We add graft particularly medially and anteriorly to assure proper position of the component. The height of the component is checked. The top of the tuberosity should be at the same level as the top of the prosthesis, as shown here. The desired 50% posterior translation on posterior drawer test is shown, along with the 70 degrees of internal rotation with the arm in abduction. These two tests indicate the appropriate tension of the posterior capsule. The subscapularis can easily be reduced back to its insertion site. We'll now repair the rotator cuff using both some mattress sutures into bone and some side-to-side sutures. Whenever possible, we prefer to perform rotator cuff tears after the prosthesis has been inserted to make sure that it is not over-tensioned. These are simple sutures going from bone through rotator cuff and back out through tuberosity bone again. These are now some inverted sutures placed from side to side, reapproximating the cuff in the sagittal plane. Note these sutures are being inserted so that the knots will be buried, staying out of the subacromial space. We now tie the cuff to tuberosity sutures, again with the knots well below the part of the cuff that will rub against the undersurface of the coracoacromial arch. Our goal, as always in cuff repair, is to assure the smoothest possible humeral surface of the humeroscapular motion interface. We're now ready to prepare the subscapularis to the lesser tuberosity using the previously placed sutures. The first goes through the upper rolled border of the subscapularis shown here. By leaving the anterior capsule on the deep surface of the subscapularis tendon, we maintain optimal strength of this tendon. This is vastly superior to other techniques, for example, that of trying to perform Z-plasty lengthenings of the subscapularis, which actually weaken its tendon. So here one can see grabbing the deep surface of the tendon and capsule as well as the superficial surface of the tendon to achieve a solid bite on the subscapularis. Tying these sutures anatomically reconstructs the subscapularis, securely allowing early motion. A drain is placed superficial to the deltoid muscle. A final irrigation of the wound and standard wound closure is carried out. We often use skin staples as a closure to allow for wound drainage. Here the patient is in postoperative continuous passive motion, which gently lifts her arm through an arc of motion early on after surgery. Here are her postoperative films showing an anatomic reconstruction in the AP and axillary views. The press fit of the humeral prosthesis in the canal using the graft is easily seen here. I hope you enjoyed the chance to see the surgery that we do. It's interesting, we find that more and more patients are interested in knowing about these surgical details and find that seeing the operation itself actually helps them understand what's going on in the recovery process. So today we have the opportunity of sharing with you a very close friend, Amy Evans, who's sitting next to me to my right, and to her right is Sarah Jackins, who's the chief of our shoulder rehabilitation program. And I think it's important that you recognize that we have Ms. Evans in the center because we do like to make the patient the center of our entire program. Now, Ms. Evans had severe arthritis of her left shoulder, and on May 11th, 1993, we just looked it up, we did a shoulder replacement on her left shoulder, and she's been kind enough to come with us today and talk a little bit about her shoulder. And Ms. Evans, maybe you could tell us a little bit about what your shoulder was like before you had your operation, in other words, when you still had arthritis.
Well, it was like nothing you'd want. It didn't work. Well, it worked, but it hurt too badly to work. Couldn't lift things. I couldn't. It was really bad, and it was very sore. And finally, I decided Dr. Matsen should do something about it, which he did. I now, do you want me to show like, I can do this, I can do this, I can do this, I can do that. I lift, I was told, you know, usually most weight in this hand. I forget and I lift whatever the heaviest thing is with my left hand, no problem at all. Absolutely no problem, no hurt. Anything else you want me to demonstrate?
That's pretty amazing.
I can reach the floor, of course. I can't get back up very easily, but
So,
I get down there.
Ms. Evans, or Amy as I like to
Yes.
call her, if that's okay, has been a great example of a patient who has decided that she needed to have the operation, was a total partner in the whole doing of the operation, and did such a terrific job of the rehabilitation afterwards. Sarah,
Thanks.
can you? Yes, thanks to Sarah. I was going to ask Sarah to tell us a little bit about how the rehab goes after a shoulder replacement. We're doing a lot of these days. We just did one yesterday, and so how does the rehabilitation go after this kind of surgery?
Well, the rehab starts that same day with exercises, and it's a thrill, really, for me and for the patient, because all of a sudden that shoulder joint moves, it's smooth, it goes up over their head, it goes out to the side. It's an exciting time. It's a little uncomfortable at first, but it's clear that the shoulder's going to be so much better, that people like you do such a wonderful job and are motivated. They have a lot of work to do. They have to do a lot of exercises, as you remember, but it goes so well and it's so easy to use their arm right away. People are combing their hair, they're brushing their teeth, they're eating, they're using their arm immediately, and it's very satisfying. And I get to be there, so I'm lucky.
So what does PT stand for anyway?
It stands for physical therapy, but we actually have the patient do all the work. I get to be there as a coach, really, and show the person their exercises, and then they carry on, and we're all just thrilled to be there, cheering you on.
So
And
this-
I don't know about other people, but the hardest exercise in the world is to go home and do exercises all by yourself. But she put the fear of whatever in me. So I had to put that thing over and pull it up, and was wonderful. And let's see, how old was I then?
8 years younger than you are
I
now.
know, but I have to figure that out. 91.8, so I was still in the 70s, and no problem, absolutely no problem with my shoulder, and no problem yet.
People often ask whether they're too young or too old for the operation, and that's an important question. We found that age is not the important decider, but it's what the patient has in terms of their motivation and their desire to get better that is the most important decider. And this operation won't cure everybody's problems. If the major problem is that people are unhappy, or if they have pain all over in their shoulder, or if they have other diagnoses like rotator cuff tears and so on, this operation is not about that. It's about a very specific problem. So one of the important parts of the exercise is that the patient and the doctor have to make sure that this is the right thing for that person at this time. And that's why that partnership begins right at the very beginning. Mm-hmm. And Sarah has been so helpful in being a part of the partnership as well. And one of the things that we've done is to try to make sure that before the patients go home, they are able to do their own exercises. And as you say, that's a big, important transition between being under the care of Sarah and the nurses at the hospital, and then going home.
And doing it all when you don't want to.
But you did it.
It interferes with your social life.
That is an important consideration. But now, hopefully, your social life is better as a result of having a better shoulder.
It was better. Right now, my social life has decreased.
A little bit.
A little bit.
Sarah, one of the things that you've developed is the use of continuous passive motion, and we saw a little bit of that in the video. Can you tell us how that works after surgery?
Sure, people are placed in it as soon as they're through with the surgery in the recovery room, and so immediately they're used to their arm moving, and it makes it work smoothly and comfortably. People really like being in it. It's a good way to make the transition to the exercises. It lets the person know.
Because it moves for you. Does
That's
it?
right.
Yeah, so
It
that would
does.
be important.
And sometimes
Because you're
people,
timid about wanting to set up some more pain.
that's right, right, but all of a sudden it's moving
in.
right away and there's just no waiting. Immediately you're into it. So I think that really allays a lot of people's fears to have that going right away when they wake up or when they start in the recovery room.
So the plan is for the person to wake up and see their arm gently moving up and down so that they have
Yes.
in their own mind the vision that this thing does work and that it is smooth. And strangely enough, the shoulder operations seem more comfortable when they're moved than when they're just put in a sling and then the exercises are started several days or weeks later.
Well, mine didn't start right off the bat. I had a little period of time that I came back to the
You did, right.
yes, because
We've
I was
advanced that.
before the,
That's right.
but it was hard for me to do them at home. I just think I sit there and think, what am I doing this for? I could, but it paid off.
Thank you for doing
Paid
that.
off.
So Amy's bringing up a very important point, which is we're trying to make it easier. And one of the ways we're trying to make it easier is to get those exercises started as soon as
I
possible
like
after
that.
the operation.
I would have liked that.
And so when you have your next shoulder, we'll be sure that it gets on the
Well, there's still one left.
There's still one left. So what we really want you to make sure that you perceive here is that the most important part of the equation is the patient, and that Amy has made her shoulder successful, and fortunately just about everybody that we've done this operation has been as successful as you have been. And she's also been very kind in helping us follow up on the results of her shoulder, because one of the things that we're very interested in knowing is what the long-term results are. So she's been a partner in a different way, in that every 6 months I send her a little letter asking if she can give us an update on how her shoulder is doing. And in that way, we have not only a short-term follow-up, 6 months or a year, but we can actually follow things for a long period of time, like up to 8 years after this replacement, and find out how we can make this a lifelong and durable operation. So again, thank you very much for the opportunity of sharing with you a few of our thoughts and advances about the art of shoulder replacement surgery. We're going to put our website address and our email up here, so if you have any questions that we can answer, we'd really be happy to do so. Thank you.